Hello. Yes. Okay. All right. So we've got some people on Zoom as well, so they might ask some questions. All right, go for it.
Thank you. Okay, good to go?
Yeah.
Awesome. Good afternoon, everybody. Thank you very much for having me. My name is Ty, and I'm an undergraduate psychology student at UNSW. And today I'll be presenting the preliminary results from an ongoing study, which we have been working on over at Neuro. Whilst I agree this is a relatively long title, I will take us step by step through the background information so that by the end of my talk, hopefully you understand a bit more about the topic. Small preface as well, I had a bit of a brain fart when submitting the slides, so I have submitted one of my drafts, so please forgive if there are any inconsistencies or any completeness in the slides. So firstly, what is obstructive sleep apnea? Well, it is a sleep breathing disorder which impacts nearly 1 billion people worldwide, and it is characterized by the recurrent collapse of the upper pharyngeal airway and leads to reduced or absent airflow known as a hypopnea or apnea, respectively. These nocturnal apneas or hypopneas lead to reduced oxygen saturation in the body and result in the activation of the sympathetic nervous system and surges in nocturnal blood pressure. And as a result, individuals will often awaken multiple times throughout the night to alleviate this stress. OSA severity is quantified using the apnea-hypopnea index, which is the average number of respiratory events per hour of sleep. And indeed, a greater AHI is associated with a range of short-term consequences, such as increased daytime fatigue and long-term consequences, such as increased risk of neurovascular disease and cognitive impairment. Now, while this relationship is quite well established, there remains several gaps in the literature which are poorly understood. Firstly, there is no general consensus in which cognitive domains are most impacted by OSA. So throughout the year, I conducted my own literature review from studies from 2016 to 2023. And mainly what I wanted to demonstrate was that even within the literature and between studies, there is a great deal of variation between the results. Secondly, the underlying pathophysiological mechanisms behind OSA are also poorly understood. And this is partially due because OSA often presents with other significant comorbidities, such as hypertension, obesity, and vascular injury, which are known to impact cognitive function. Therefore, the independent effect of OSA is often confounded by the presence of other major comorbidities. And finally, brain imaging techniques are often neglected in this when investigating the relationship between OSA and cognition. And this is actually quite important to note because OSA-related cognitive impairment does not occur overnight. It is the prolonged exposure to OSA pathophysiology which causes structural damage to brain regions associated with cognitive function. So, cerebral small vessel disease, or CSVD, is a neurovascular disease quite commonly found in aging individuals and may provide an explanation or a link between OSA and the variation in cognitive function. It is thought to contribute to 25% of stroke and 50% of dementia cases worldwide, and is associated with OSA as acute physiological responses of OSA. In particular, nocturnal blood pressure surges are thought to contribute to the development and progression of CSVD. Just quite briefly, CSVD is scored along a scale of 0 to 4, and it tallies the presence of recent vascular injuries as listed on the screen. An individual is deemed to have CSVD if they have a score of 1 or greater. So, quick summary of the background information. So firstly, OSA and CSVD are closely related, and as OSA severity increases, as does the severity of CSVD. Furthermore, no comprehensive study has looked at OSA, CSVD, and cognitive function together as one, and nocturnal blood pressures, which represent a lesser investigated pathophysiological mechanism of OSA, may contribute to CSVD, and that is because historically it's quite difficult to measure blood pressure overnight. So what we aimed to do was to determine the extent to which nocturnal blood pressure surges is associated with CSVD severity and cognitive performance in individuals with untreated OSA and who are free of other major comorbidities. We hypothesized that a higher frequency of nocturnal blood pressure surges individuals with a higher frequency of nocturnal blood pressure surges would have a higher CSVD severity and lower cognitive performance. And what we did was we took 7 healthy controls and 21 individuals with OSA and recruited them along a strict non-comorbid and untreated OSA criteria. The age ranged from 45 to 65 years of age with a mean age of 55. We first took demographic inventory and medical history to account for previous or current comorbidities. Furthermore, they underwent an overnight polysomnography or a sleep study from which we collected a range of sleep parameters. But in particular, we collected, the apnea-hypopnea index along with the frequency of nocturnal blood pressure surges, which was considered to be at least a 10% increase in nocturnal systolic blood pressure. We also took participant fasting blood draws to measure blood glucose, cholesterol, and markers of inflammation, and an MRI scan was used to diagnose and stage the severity of CSVD. Finally, participants also underwent a comprehensive neuropsychological test battery, which covered 7 major cognitive domains. And overall cognitive performance across the neuropsychological test was given by the mean T-score, which was an average across the 7 cognitive domains. And finally, cognitive impairment was given by the global deficit score. So moving on to the demographic results, we can see that is a relatively young, with a mean age of 55 years, an educated cohort, and furthermore that there are no differences in risk factors. So the levels of glucose, cholesterol, and lipid levels are all similar between groups. We also find that individuals with OSA and controls had similar sleep parameters between groups. So obviously, OSA individuals had a greater AHI than controls, but in terms of the frequency of blood pressure surges, the total sleep time and sleep efficiency, they all had similar levels. However, we do observe distinct physiological markers of damage in participants with OSA. For example, the OSA group had elevated levels of hsCRP, which is a marker of inflammation, and they also had elevated levels of seated systolic and diastolic blood pressure. In terms of the cognitive performance, there was really no difference between groups of OSA and healthy controls. And additionally, all participants had normal cognition, with only 1 male with severe OSA deemed to have cognitive impairment throughout the whole cohort. So moving on to the brain imaging aspect of the study, we find that out of the 28 participants, 21 of them had CSVD, and in the OSA patients, 81% of them had CSVD, and in healthy controls, 47% had CSVD. Furthermore, our results tended to agree with previous literature and showed that the presence of CSVD was associated with a greater OSA severity. That being said, there was no association found between CSVD status and cognitive performance as measured by the mean T-score. And further, there was no association found between the CSVD status and the frequency of nocturnal blood pressure surges. Finally, when looking at the potential influence of nocturnal blood pressure surges, because we had a small sample size due to it being a pilot study, we took into account the correlational effect sizes. And what we found was that individuals who experienced a greater frequency of nocturnal blood pressure surges tended to be associated with decreased cognitive performance with a moderate effect size, so standard beta of 0.33. Furthermore, individuals who experience a greater frequency of nocturnal blood pressure surges tended to be associated with increased CSVD score severity with a large effect size. And this is represented by this figure here, showing that as the CSVD severity increases, as does the frequency of nocturnal blood pressure surges. So in conclusion, the preliminary results from this ongoing study suggest that the frequency of nocturnal blood pressure surges contributes to lower cognitive performance, though with a moderate effect size, and also higher CSVD severity with a large effect size in people with untreated OSA and who are free of other major comorbidities. These trends are of particular clinical significance simply because OSA represents a treatable risk factor of dementia. Furthermore, the results of our findings are also promising and perhaps present nocturnal blood pressure surges as a target of intervention for OSA and further long-term sequelae. That being said, analysis in a larger sample size is warranted. Finally, I would like to acknowledge everyone on the screen for supporting me throughout the year and providing me with insight, especially Dr. Lorian, who has provided me with the opportunity to present today. So thank you.
That's great. So this paper is open for questions. Anyone? Dr. Butler?
Hi, thanks. So I guess I thought the blood pressure surges were related to arousals, but then you show that the incidence of the surges was similar between the controls and the OSA participants. So what's causing the blood pressure surges, and is it the magnitude of the surges that's important rather than the number?
Yeah, that's a great question. So the measure of OSA that we use, the apnea-hypopnea index, is not the only one used to measure the severity of OSA, but it's just the standardized, most common one in the field. And it actually has several limitations. So it only measures the frequency of the respiratory events, and it doesn't really measure the depth or the severity. So these people could have like a small apnea, hypopnea, but in terms of arousal and a physiological response that you get, there might not be too much of that. So it's just one aspect that we've looked at in terms of the nocturnal blood pressure arousals. And, you know, there's a bit missing at the moment because I've had to keep it quite short. Yeah.
Hello. I think the presentation in the study is actually very interesting. I just got a couple of questions. Maybe the first one is, how did you actually measure cognitive performance? Was that like a subjective way at the end of the study for each candidate? Is that what you did?
No. So we conducted it with a neuropsychologist, and they did about 90 minutes running through 7 different major cognitive domains.
Yeah.
And this was standardized, so their performance was matched for their age.
So the problem I have with that is it's actually not a real-time testing that you can actually use physiological tests can actually tell about the patient's cognitive impairment. Did you consider that? Because you're measuring blood pressure, but you could easily measure heart rate as well. As you know, heart rate variability can actually be used as an indicator for cognitive performance.
Yeah, for sure. So we did measure heart rate variability and a lot of other stuff were included. However, like I said, this is an ongoing study and the scope of my research was not really, did not include what you were mentioning, but yeah, we'll take that into consideration, sure.
And just a comment, I think it's what you said is quite interesting in that potentially you could put patients on CPAP and see whether these blood pressure surges actually reduce when they're actually on treatment. So that would be an interesting part that you could add on towards the end.
Yeah.
And Ty, just one from me. Could you just outline your role in the various findings that you've presented today?
Yeah, for sure. So I assisted with the data analysis of the sleep findings, mainly because I was part of psychology instead of medicine. So I joined the team at Neuro, and a lot of the data collected from the sleep, it was run through a code where it matched like blood pressure surge frequency and AHIs. And another aspect of the study is ones which are linked to respiratory events, like blood pressure surges, which are linked to respiratory events. So mainly in terms of the data analysis.
Okay, thank you. And just one last question from me. You said larger numbers are needed. So what's your calculation for your next study?
Well, we aim to have 20 participants in each group. However, this was the study was started before COVID-19 and it was delayed afterwards as well. So it's still we're still recruiting participants at the moment. And what we find is that those who are recruited as controls actually end up having OSA itself. So that's why we had a lot more individuals with OSA compared to the controls.
Thank you. Any other questions? No? Okay. Thank you, Ty. Well done. Thank you. Okay, and our next speaker, Kate. All right, just go, Kate. It's all set up. Okay, Stacey.
Good afternoon, everyone. I'd like to begin by thanking the committee for the opportunity to present today. My name is Kate. I'm a fourth-year medical student, and I spent my ILP honours research year in the Department of Newborn Care. And my project is on neurodevelopmental outcomes in extreme preterm infants treated with early paracetamol for patent ductus arteriosus. Extreme preterm infants, like this little one, are the tiniest of our preemie babies born less than 28 weeks old. 80% face a critical heart condition called patent ductus arteriosus, or PDA, which is caused when a vessel connecting the big arteries of the heart fails to close after birth. This leads to lung and brain bleeding, gut injuries, and heart dysfunction. Some babies don't make it. Doctors use non-steroidal anti-inflammatory drugs, or NSAIDs, such as ibuprofen and indomethacin, to close the vessel quickly, but this can be poisonous to these tiny babies, causing bleeding from gut ulcers and kidney failure. Treatment is a very precarious balancing act, and the need for a safer alternative is urgent. Recently, paracetamol has been of interest to neonatologists due to its favourable side effect profile. Remarkably, this household staple has also been shown to effectively close the vessel, sparing these infants from the consequences of traditional treatment. Paracetamol is excellent in the short term. However, there's limited long-term safety data regarding its use in the preterm population. Perhaps even more concerning is that some studies have suggested that prolonged exposure to paracetamol during pregnancy may increase the risk of behavioural disorders such as ADHD and autism spectrum disorder later in life in children. As data is limited, we don't know if these concerns can extrapolate to exposure after birth. Therefore, we must assess the long-term safety outcomes in newborns, particularly in our youngest and most vulnerable of these, our extreme preterms. However, currently there is no data on the long-term safety of paracetamol in extreme preterm infants when given soon after birth. 4 years ago, a pilot trial called EPA was conducted at the Royal Hospital for Women's NICU, and this study aimed to determine if early administration of paracetamol to extreme preterm infants could reduce the number needing intervention for PDA. This trial included 58 babies born less than 29 weeks of gestation, and they received either IV paracetamol or IV dextrose as a placebo less than 6 hours after birth. The trial was stopped at 50% recruitment due to significant benefits to the group receiving paracetamol. Long-term outcome data is now available for the infants who were involved in this study, providing a rare opportunity to investigate the neurodevelopmental impact of giving paracetamol to extreme preterm infants in the immediate postnatal period. This formed the aim for our study, as I aimed to report the neurodevelopmental outcomes of extreme preterm infants treated with early paracetamol in the EPA trial. We hypothesised that there will be no difference in neurodevelopmental outcomes between infants in the trial who received paracetamol compared to those who received a placebo. At the Royal Hospital for Women, all infants are assessed at the Growth and Development Clinic at regular intervals to check their development. They're assessed at 4, 8, and 12 to 24 months using standardised assessment tools. And the results of these assessments are stored in a database called NICUS. So for data collection, I extracted the results for the 58 infants who were involved in the EPA study for each of these assessments. In terms of follow-up, there were 8 infants that didn't attend the clinic at any age and so were lost to follow-up. 34 attended at 4 months, 32 at 8 months, and 42 at 12 to 24 months. So the 12 to 24-month assessment is also the most comprehensive. It uses a tool called the Bayley's 3, which assesses development over cognitive, language, and motor domains. So because of this, combined with the fact we had the highest rate of follow-up at this age, meant we selected data from this assessment for primary analysis. But we did also use data from the 4 and 8 month assessments in a subgroup analysis as well. Our primary outcome was neurodevelopmental impairment. And this was defined as presence of developmental delay, presence of motor delay, cerebral palsy, presence of hearing loss, which was defined as having cochlear implants or hearing aids, and vision impairment, which was defined as visual acuity less than 6 on 60 in the better eye. Each of these components was also analysed separately as a secondary outcome. Statistical analysis was performed using SPSS version 27, and each of our primary and secondary outcomes was summarised as a binary outcome. And so we compared these using a chi-squared or Fisher's exact test where appropriate. And we also compared Bayley's score means for each of the domains, so cognitive, language, and motor. And so the means between the groups were compared using a two-sided independent samples t-test. So what did we find? Analysis of the primary outcome showed that 26% of individuals who received paracetamol experienced neurodevelopmental impairment, compared with 44% in the placebo group. Majority of these cases were mild in both groups. However, this difference was not statistically significant, with a p-value of 0.248, indicating that both groups had similar long-term outcomes. Similar findings were seen with analysis of secondary outcomes, with no statistically significant differences between the groups for developmental delay or motor delay cerebral palsy. There was one case of hearing loss and no cases of vision impairment, and so these outcomes were unable to be properly analysed. There were also 2 cases of cerebral palsy diagnosed, and there was 1 in each group. Comparison of the Bayley's score means also revealed no significant differences between the 2 groups. So we found early paracetamol to be safe with no elevated risk of neurodevelopmental impairment up to 12 to 24 months. And this is the first study to assess neurodevelopmental outcomes in extreme preterm infants who received paracetamol soon after birth. And these findings have implications beyond treating patent ductus arteriosus. A recent French study with over 30,000 participants found that estimated that 65% of infants aged less than 27 weeks old received paracetamol for pain relief. So these results are quite reassuring when considering the extensive use of paracetamol in the extreme preterm population. Our main limitation was sample size. So we had 42 infants, and this did not provide enough statistical power to have a high probability of correctly detecting a difference between the 2 groups if there was one. And this sample size also hindered the detection of rare adverse outcomes. So an example of this is that there were no cases of vision impairment in either group, and so we couldn't analyse this outcome. We also lost follow-up past 24 months. Behavioural disorders, as well as mild cases of cerebral palsy, are difficult to diagnose until later in life. So it would have been ideal to have a longer follow-up period. So to conclude, although these results are from quite a small study, but what they did indicate in our study is that early paracetamol was safe for our infants up to 2 years. And this is a reassuring finding given the vulnerability of this group, but we do need larger and longer trials with enough statistical power in order to properly confirm safety in this vulnerable population. This is difficult to achieve in a reasonable time frame, particularly at a single institution. So further studies should aim to collaborate between local and international hospitals. They should also aim to follow up past 2 years, ideally to 5, and longer would be great too, in order to provide insight into childhood outcomes, particularly behavioural disorders. Nevertheless, this study is a remarkable first step in safeguarding some of our tiniest lives. And I'd like to finish by acknowledging the neonatology department that were super helpful with this assignment, and particularly Associate Professor Tim Schindler, who was my supervisor and provided lots of advice and support. So that was awesome. But yeah, thank you very much.
Thank you, Phil. Okay, open for questions, anyone? Sam, oh, why do you have to sit there?
I've got a
Oh, you. Okay.
Thanks, Kate. Can I just, obviously, it's part of a bigger study, and 4 years ago you weren't doing ILP or honours. What was your role in the study?
Yeah, so in terms of, this follow-up, I extracted the data for the 58 infants who were involved in the study from the NICUS database. So looking at all their growth and development clinic results. Cleaned the data, analysed the data, and then wrote it up in my manuscript. And then also did a literature review at the start to kind of see what we know so far. So, yeah.
And do you have a manuscript and the pipeline for publishing or
there
presenting
is.
elsewhere?
There's one on the go. So, hopefully looking at getting that published as well.
Great, thank you.
I think it was a very interesting study, Kate. But what I didn't quite understand was the concern that Panadol was going to cause neurodevelopmental sort of problems? Was that the concern?
So there was these studies in like prenatal studies. So suggesting that exposure, if mum takes Panadol when she's pregnant, that it may lead to behavioural disorders in children. And currently the only research looking at long-term outcomes when preemie babies exposed to paracetamol are on very preterm babies, so 32 weeks or older. And so there's kind of this gap between when they're born and up to 32 weeks, so the extreme preterms. And so we're wondering if the concerning data with prenatal exposure could be extrapolated to exposure after birth. But thankfully we found that it wasn't.
You probably found the opposite actually. The numbers weren't big, but you actually found people had Panadol and maybe early closure actually did better. Is that right?
That's what it looks like, but that result was also not statistically significant. So I think I'd be hesitant to conclude that.
Thank you.
Yeah, it looked like it could go that way.
I just wanted to check a few things, maybe I missed it. With the paracetamol versus placebo, was the placebo group a group that also had PDAs? And if they did they get standard treatment? And what would you do if the paracetamol failed for the kids in your study? And then also with the neurodevelopmental follow-up, did you standardize the groups for things like gestation and gender that would also affect outcomes?
So your first question was, so the treatments. So I wasn't actually a part of that study, but the infants who received paracetamol and placebo, they all had a patent Ductus arteriosus, and I believe it was bigger than 0.9 millimeters, and they were kind of like randomized to the two groups. And I think the treatment was at the discretion of the treating neonatologist. And so if there were concerns, then they were given standard treatment if that was needed. Does that help? And then in terms of neurodevelopment, so we did baseline demographic descriptive statistics for the infants in our study. And there were no like differences between the two groups with all like maternal age and all those kind of things. But,
Steve?
Hey, just quickly, what was the dose of paracetamol that was used in relation to what might be used on the ward?
So the infants received an initial dose of 15 milligrams per kilogram at the beginning, followed by 7.5 milligrams per kilogram every 6 hours for 5 days. And I think this is similar to the doses received for analgesia as well.
And one last question from me. You had, sorry, you go first. Oh, yeah. Oh, sorry, I didn't see you. Your mic's not on, I think.
Great presentation, thank you. I was just wondering, with the sample size that you got, what was the power and what sort of sample size would you need to get, say, power of 80% or something that you could sort of base more strong conclusions on?
So our sample size was based on, I guess, the EPAS study, which was initially powered to their primary outcome, which was assessing PDA closure. So we actually did a calculation on it, which I've got here. So assuming an expected incidence rate of 25% in our population of neurodevelopmental impairment, which is based on current literature, and aiming to detect a 5% difference between the groups in incidence, we would actually need 2,502 infants, so about 1,250 in both groups. And that's with an alpha of 0.05 and power of 80%. Yeah, which is why one of the main recommendations is collaboration between multiple hospitals, because it's just, yeah, it's such quite a big sample size and such a, minority group of babies. Yeah.
Thank you.
Thank you. That's a great question. I was going to ask something similar because in your last slide, you said, Kate, that paracetamol is safe. I don't think you can say that, unfortunately, from this study. So be careful of that when you write up your manuscript. Anyway, thank you very much.
Pleasure.
Well done. Great answers, and we'll move on. Thank you. Okay, Jason. Jason. Okay, you're familiar mouse with, yeah, the arrow? Thank you.
All right. Okay, good afternoon all. My name is Jason and it's an absolute honor to have the opportunity to present my project today, characterizing common phenotypes across the childhood dementia disorders. So this was a cross-sectional study from centers in Sydney Kids Network in Sydney, of course, and Adelaide as well. So childhood dementia. Hearing these words together may shock you. Let me quickly share the story of Mia, who had Batten disease, one of the childhood dementias. Her story is like many of the children included in this study. 2 months after her diagnosis, Mia could walk, run, and talk like any other 3-year-old. 5 years later, her parents gradually watched her lose those skills. She could no longer walk, talk, nor see. Mia tragically passed away, aged 8, in 2018. Hearing dementia in the context of childhood may be a new and challenging concept. How can children be affected by dementia? Dementia itself is an umbrella term for a group of progressive neurodegenerative disorders which affect cognition and one's ability to perform everyday functions. Although more commonly associated in older people, there is growing awareness that it can affect all ages, and it is not one specific disease. Similarly, the childhood dementias are a group of devastating pediatric neurodegenerative disorders which share overlapping disease mechanisms and clinical phenotypes. Whilst every child is different, they are all characterized by progressive cognitive decline and an overall regression in function and developmental skills, as highlighted by the purple line in this diagram. A recent scoping review published in Brain identified over 170 genetic conditions associated with childhood dementia, with a collective estimated incidence of 1 in 2,900 births, similar to that of cystic fibrosis. However, it is estimated that less than 5% currently have disease-modifying treatment, and tragically, around 70% have a life expectancy under the age of 18. Of these 170 conditions, many are ultra-rare, with individual incidences of 1 in 100,000 births or less. And hence, research efforts to date have been largely limited in their scope and their scale. Taking a collective approach founded on the shared clinical dementia aims to raise awareness, interdisciplinary collaboration, and resource sharing. With rapid advancements in gene therapies and clinical trials for rare disease, it is anticipated that this field may be close to developing novel treatments. However, to streamline the evaluation of the efficacy and safety of these treatments, there's a great need to develop a common toolkit of clinical outcome measures, sensitive assessment tools, and informative biomarkers. To get there, we first need to ascertain the unmet clinical needs and quantify the broad scale and severity of these conditions. Identifying the most prevalent phenotypes and meaningful symptoms to target is the foundation to developing these tools and improve research and care in the field. This is the primary aim of this study, to quantify and characterize these phenotypes and the meaningful symptoms to target. So for it, children were identified through various avenues. And if they were under the age of 18 and met the study inclusion criteria for dementia seen here, their caregivers were invited to complete the survey. This consisted of customized questions and various validated screening and assessment tools. All measures were parent reported, and quantitative data was collected and analyzed with descriptive statistics. On to results. 63 children were invited to the study and 45 ultimately included. This table highlights the 22 distinct known childhood dementia conditions which are represented. Considering the rarity and ultra-rarity of many of these conditions, this was a substantial number that highlights the strength of a collective approach to raise visibility. In terms of the cohort itself, the mean age was 9.2 years. The average diagnostic delay was 1.6 years, and for 10 children, it took over 3 years to reach a diagnosis. Literature into some of the individual conditions has described the impact of this delay on caregivers, including anxiety, uncertainty, and the cost of unnecessary testing. Achieving more timely diagnosis is important to optimize therapeutic windows as treatments become available. We identified a broad range of clinical commonalities from looking at these disorders collectively. The top 5 most prevalent symptoms were impairments in cognition, changes in sleep, changes in appetite and eating, loss of mobility, and behavioral challenges as seen here. Now, although dementia is fundamentally cognitive, this graph highlights the wide range of disability and functional impairments in these children. All these disturbances broadly mirror the multi-system degeneration seen in adult onset dementia, albeit at a much earlier age. These are important outcomes to target and improve best practice care and support. So cognitive impairments were the core clinical phenotype. Just under half the cohort were unable to communicate their basic needs, either verbally or non-verbally. Caregivers reported difficulty following or understanding instructions most of the time in 69% of children. And regarding memory, for 11 children, this could not be assessed due to significant communication difficulties. For the remaining 34 children that could be assessed, 27 were reported to have some difficulty recognizing familiar people or recalling recent routines and items and events. So 80% of children had sleep difficulties, occurring at least 2 or more days a week, as highlighted by this graph. Expanding further on the examined subscales, the most substantial disturbance was with frequent night waking, with occurring at least 2 days a week for more than 95% of children. Of note, there were 16 children who woke more than 3 times a night for 4 or more days a week. Targeting sleep would be critical to improve both child and caregiver health and well-being. This graph illustrates the results of the Strengths and Difficulties questionnaire, which is a validated tool we use to screen for behavioral challenges. In a normal population, 10% are expected to score atypically, as represented by the dotted line. And as you can see, this cohort scored higher than expected in all domains, but particularly in hyperactivity, peer problems, and low social behavior, whereby almost 50% had an atypical score, which is 5 times higher than an age-matched population. Improving behavior would be a meaningful outcome. So coming back to this diagram, note that 30% or more of children experience a wide range of extracognitive or behavioral symptoms. Of note, motor function was significantly impaired, with over half needing assistance for daily movement and 40% in a manual wheelchair at all settings. Future care guidelines should address the preservation and promotion of independent function and disability support. There was a high burden of medication use, with over 82% of children on regular medications. The most common indications were for epilepsy, sleep, reflux or constipation, and behavior. 17 children were on 5 or more medications, meeting the definition of polypharmacy, and 12 received additional multivitamins and supplements. Although this study did not analyze the financial impact on these families, nor the cost of treatments themselves, this will be an important area for future consideration considering this data. Are there areas of improvement in prescribing? Our study highlighted some potential gaps. As highlighted previously, 36 children had difficulties with sleep at least 2 days a week. Despite this, less than half were on a medication for it. 22 children were reported to experience regular pain, scored by a visual analog scale, yet only 9 were receiving pain medications. And 20 children were reported to have regular seizures, and all 20 were on anti-epileptic therapy, suggesting that these may be treatment-resistant phenotypes. There are many likely contributors to these current discrepancies in care. These include a paucity of available effective treatments or a lack of consensus guidelines in this field that help manage these complex care needs. So taking a collective approach to these individually rare disorders allowed us to identify the most frequent and severe symptoms at a much larger scale. We are the first study to attempt to characterize these disorders under one umbrella term and thus spearhead the development of robust outcome measures to evaluate trials in the future. Our sample size of 45 was relatively large, considering the small incidences in rare disease and our short time frame of data collection. Most health professionals may only see one of these disorders in their entire career, and this further highlights the strength of a collective approach to raise visibility. And lastly, our study strengthens the choice of childhood dementia as an effective term, which illuminates the common needs that are broadly similar to those seen in traditional adult onset dementia. Some limitations include a potential selection bias, as clinicians tended to refer families who they felt had the capacity to complete the survey in the first place, wary of causing undue harm. A challenge in a pediatric cohort is how one should appropriately measure cognition given the various developmental stages. As an exploratory study, we do not examine higher functions such as reasoning, planning, or visuospatial awareness. In addition, there's a high prevalence of physical limitations which may mask cognitive impairment as well. And finally, not all the known conditions were represented. So in conclusion, childhood dementia disorders share substantial behavioral, motor, sensory, and socio-emotional symptoms, resulting in high and complex care needs. Considering the unifying characteristics under one collective term is an opportunity to improve treatment, quality care, and accelerate research. And this data will help guide the development of a standardized toolkit to evaluate therapies and conduct sensitive clinical assessments. In future, identifying informative biomarkers is an important next step to developing this toolkit. And furthermore, whilst acceptance of the term has been largely adopted and elucidated amongst caregiver and patient support groups, there is a need to gather opinions from wider stakeholders and particularly healthcare professionals. I'd like to thank all who helped me out with this project, particularly the families of the children with dementia. These are my references and any questions.
Thank you, Jason. Any questions? Anyone? Sam?
Thanks, Jason. I think that's the second talk I've heard in the last 6 weeks on childhood dementia, and it's not getting any easier to listen to. Not your presentation, of course. I just wanted to ask, so yeah, being a rare disease, or a group of rare diseases, 45 is quite a lot. Was it a multi-site study? How did the recruitment work?
Yeah, so the recruitment was through 2 networks. So one was through hospitals. So I presented at Sydney Kids Westmead as well as Sydney Kids in Randwick as well. And they also recruited John Hunter through that. And also through advertisements through some of the disease-specific organizations. Childhood Dementia Initiative, which is an amazing patient support organization, helped us with flyers, and that also put us in contact with Adelaide. So when Dr. Nicholas Smith at Women and Children's Hospital Adelaide, and then from there, recruitment was sent, invitations sent to families. I also visited a few of the clinics to, if they're with their consent, to have them complete the survey as well. So yeah, multi-center.
That was actually quite a good presentation there, Jason. I'll just go with a couple of questions. A lot of symptoms sort of seem very similar to sort of children who have developmental delay. So, and you sort of mentioned that like by a lot of those children that you sort of found actually had delayed diagnosis, but even though they weren't given a term, they probably were still getting treatment for their other symptoms like epilepsy, constipation, sleep. So therefore, even though they didn't have a term, they were still getting the appropriate treatment. Would that be right?
I think that's a great question. I think there's a slight challenge there is that with developmental delay, it's expected to be either a static decline or they're still improving slowly. Whereas in these cases, what the families found that was most distressing was that they would lose skills. And so you'd have children who are starting to walk and then they'd have, they'd lose those abilities and then they come back to the doctor and that wasn't explained with my original diagnosis, what's going on. And there's that continuous cycle of uncertainty is what childhood dementia as a term is attempting to address, that kind of gap in awareness in some ways. For some of the key phenotypes like epilepsy, I assumed that they would have been treated, but there are wider system disturbances seen here, such as behavior, sleep, which may be more subtle and under-recognized. And that's kind of the goal of this study was to shed light on these unmet needs.
Thank you.
Jason, could you just outline your role in all this?
Yeah, of course. So I was in charge of almost all of the recruitment for these studies. So when I first started, I'd never heard of childhood dementia before either. And there was only one paper published in the literature on it. And so a lot of my original recruitment work was presenting to clinicians and also to families who weren't connected with Childhood Dementia Initiative originally to explain what this term is and why, what particularly Childhood Dementia Initiative think is so valuable, and we saw it as well. And so that involved me visiting, presenting at journal clubs as well as recruiting in the individual clinics themselves. I was then in charge of all the data analysis as well. And I can't say all that without the help of my wonderful team as well, who helped with some of the cross-checking, and also a lot of the co-authors helped refer families to the study, as it's been really difficult given how rare these are. Thank you. Thank you.
Oh, we've got lots of extra slides, Susan.
Oh, sorry.
Ooh, okay, no, that's okay. We'll just scroll through it. Lots of time. Go, Isabella.
Thank you.
So hi everyone, my name is Isabella. I've just finished my 4th year and my honours project was on the role of sirolimus in the management of complex vascular anomalies in children. This was completed at Sydney Kids under the supervision of Professor Morgan and Professor Adams. And I'd also like to thank Dr. Russell and Dr. Jackson for the clinical data. So vascular anomalies encompass a broad spectrum of lymphatic, blood vessel, and soft tissue conditions caused by a range of inherited and somatic genetic mutations. These lesions vary from inconsequential vascular stains to rare and complex lesions, which can be associated with disfigurement, chronic pain, and potentially death. Historically, the treatment of vascular anomalies has included physiotherapy, sclerotherapy, embolization, or surgical resection. However, there's no clear treatment algorithm, and for complex vascular anomalies, these treatments are rarely curative. So sirolimus is an mTOR inhibitor, which was first used for immunosuppression in renal transplantation. And it's been increasingly used to treat vascular anomalies arising from mutations in the PIK3CA, AKT, and mTOR genetic pathway, including slow flow vascular malformations like lymphatic and venous malformations. However, evidence of its efficacy and in prospective studies, and particularly regarding the optimal dosage and treatment regimen, remain undefined. So this is because previous studies failed to utilize standardized response and toxicity criteria in such a diverse patient population. As such, our single-center cohort study aimed to determine the safety, efficacy, and acceptability of oral sirolimus in treating vascular anomalies in children. These measures included change in lesion size and pain scores using radiologic imaging and Wong-Baker Faces scores, respectively, side effects and hematological parameters, and the quality of life scores using the PEDS-QL tools. So patients were reviewed weekly for the first month, monthly for the next 2 months, and quarterly thereafter. Blood levels of sirolimus were also monitored, aiming for 10 to 15 nanograms per milliliter based on the dosage as an immunosuppressant in renal transplantation. However, this threshold guided the toxicity range, and we allowed for adjustments based on each patient's response and adverse effects. We used statistical tests to assess the relationship between the variables of sirolimus level and patient age and the outcomes of lesion size and change in pain. Comparison of the outcomes between vascular anomaly subtypes was also performed where possible. So we recruited 29 patients between June 2017 and September 2023, consisting of 10 males and 19 females. The age at commencement ranged from 1 day old to 18 years old, with a median age of 7.9 years. 34.5% of the cohort was treatment naive, while 65.5% had a previous treatment consisting of a range of modalities like sclerotherapy, anticoagulation, surgical debulking, radiofrequency ablation, and/or embolization. 13.8% of treatments received treatment concurrently with sirolimus, and these included anticoagulation or sclerotherapy. These patients in the cohort had a range of vascular anomalies, with the largest subtypes that we recruited, including lymphatic anomalies, venous malformations, and mixed malformations, predominantly of the veno-lymphatic subtype. So 15 patients received oral sirolimus for more than 12 months, of whom 12 were evaluable for a change in lesion size at 12 months. 3 patients were lost to follow-up. 8 patients received sirolimus for less than 12 months and are still continuing, while 6 patients ceased sirolimus before 12 months for the reasons listed. So 91.7% of patients had a decreased lesion size, and 1 patient experienced complete lesion resolution. No patients experienced lesion growth. 80% of patients experienced an improvement of their pain, with 5 patients experiencing complete pain resolution. This allowed patients to wean pain medication, including ketamine and gabapentin, that they were taking for anomaly-associated pain. Finally, 87.5% of patients reported an improved quality of life. Improvements were experienced without change in lesion size and included increased participation of sports, decreased episodes of bleeding, and reduced school absenteeism. Notably, the median sirolimus level across all patients during the first 12 months of treatment was 6.1 nanograms per milliliter, with patients achieving responses at a range of sirolimus levels. Success at a lower trough level was demonstrated by 1 patient with a complete resolution of his lymphatic malformation. This existed at the left upper arm and the axilla and encircled the neurovascular bundle. This was achieved at an average sirolimus level of 4.9 nanograms per milliliter. Sirolimus level and patient age did not have a statistically significant effect on outcomes, nor is there a difference in pain levels across different types of vascular anomalies. Overall, sirolimus was well tolerated. Minor side effects were relatively common, with 62.1% of patients experiencing at least one side effect. Major side effects were rare. 2 patients experienced oral ulcers and headaches, which led to sirolimus cessation at 3 weeks and 9 months, respectively. So overall, this study affirms that oral sirolimus is a safe and effective treatment for most patients with vascular anomalies. Our study is the first of its kind in Australia to support this finding, strengthened by the use of validated tools to increase the internal and external validity and reliability. Importantly, the achievement of these outcomes at a lower trough range compared to previous studies implies that the relationship between sirolimus level and response may not be dose dependent. The main limitation of the present cohort was underpowering, which meant that we couldn't statistically stratify outcomes by the type of vascular anomaly, anatomical lesion location, or lesion genotype. We also couldn't control for therapies prior to or concomitant with sirolimus, which may have confounded the results. The high rate of lesion size reduction with sirolimus is in keeping with most studies. However, the range of responses that are noted across previous studies may be due to variable follow-up periods and study endpoints, as well as differences in the type of vascular anomalies represented by each cohort. The efficacy of sirolimus in reducing the lymphatic component of vascular anomalies implies that it may be useful as a neoadjuvant treatment for excision of more localized superficial vascular anomalies. However, its potential to cause delayed wound healing as an immunosuppressant needs to be further researched. Furthermore, genotyping of lesions should be used more to guide treatment, rather than relying on phenotype alone. This was demonstrated by variable responses in patients with a venous component to their lesion, as that anomaly can be associated with 7 other mutations aside from the PIK3CA genetic mutation, and patients may be diagnosed on the basis of phenotype without genotype testing. Moreover, sirolimus was shown to be an effective form of pain relief in most patients, which may correlate with an improved quality of life. This was experienced even when there was no change in lesion size, implying that sirolimus may have positive effects on outcomes and factors that we didn't measure, such as bleeding. The positive outcomes for pain and quality of life also suggest that sirolimus should be a first-line medical treatment for pain in eligible vascular anomalies rather than a last resort. Clearer vascular anomaly treatment protocols should be established in future to further recognize this. And as the study of this cohort continues, we aim to use the Obama questionnaire to further assess and highlight the importance of patient-reported outcomes to complement the clinician's assessment of the vascular anomaly and the success of treatment. So clearer universal criteria and reporting of these outcomes is important in such a complicated and diverse patient population. The overall assessment of low-grade side effects within this cohort was on the lower end of previously observed rates, with a lower incidence of headaches also observed. This may support the hypothesis that trough levels of sirolimus influence the frequency rather than the severity of side effects. However, differences across patient cohorts may again confound these findings. Long-term side effects continue to be monitored as patients continue sirolimus beyond 12 months, presenting a future direction for this cohort. At this point, only a small number have continued, but we have not noted any long-term side effects. An Australian multi-centre prospective cohort study of sirolimus in the treatment of paediatric vascular anomalies would be a promising next step, with the following data representing things that we would collect from the cohort to better define treatment protocols. This study also broadens perspectives for future therapies targeting specific molecular pathways and offers hope for patients with complex vascular anomalies. This is my reference slide and my statement of contribution. Thank you.
Thank you, Isabella. Okay, question, a quick question. You had the babies from as young as 1 day to many, many weeks. So you treated them as young as 1 day?
Yes, so,
Okay.
oh, sorry.
Yeah, no. Was there any difference in the side effects with those babies?
It's a good question. So in terms of the age of initiation, it really depends upon when they were diagnosed with a vascular anomaly, because this has been increasingly used. So the patient who was 1 day old and received it was started on it very recently, whereas the one who was 18 years old started a long time ago when it wasn't common. In terms of the side effects in younger patients, we tended to notice more hematological parameters that were deranged. So things like hypertriglyceridemia were noted in younger patients. We also noted hypercholesterolemia in those younger patients specifically. And in the one who was 1 day old, we also had hypertension, which was caused by giving him a very tiny dose of sirolimus, but a huge trough level was noted in his system. So it was mostly hematological, but they did resolve once we decreased the dose. So it wasn't long lasting.
Thank you. Okay, questions from Sam?
Thank you. And I can see there that Orly and Susan conceived the project, but I just wondered, your background of the project, whether how consumers were involved in the conception?
Do you mean consumers as in like the patients themselves or?
And so not the ones participating in the study, but yeah, people and families and things that may have had the vascular malformations, how they helped to, inform this, how the study was designed. But like I say, you might not know that since you didn't conceive it, but just wondering.
Yes, that's a good question. So in terms of what we wanted to look at from the clinician's point of view, that was mainly the efficacy of treatment and also the side effects and safety. With the patient side of view and how they informed the study, it was mostly with the reporting of patient outcomes, such as things that they report like their school performance, their participation in sports, and their experience on the medication. So a lot of times that also came down to the side effects noted, and they kept a diary of those very commonly. And we were also able to sort of increase or decrease a dose, again, based on their compliance and different times of the day it was given, and how they preferred to take the medication and what their parents liked. So they shaped the experience of administering the medication as well as those patient-reported outcomes. And from a clinical point of view, that's where we had the efficacy of treatment and the overall vascular anomaly response.
Any other questions?
No, Isabella, I realise the numbers will be small, but do you have a feel for the efficacy of sirolimus when used as monotherapy as compared to in combination with other modalities?
It's a good question. And I can't say it's something that we can look at from our study just because the numbers of the monotherapy were very small. And looking at the other papers as well, it's very rare to find a large study of sirolimus, and case reports really focus on it more as a last resort treatment. In terms of looking at it as a monotherapy and what we're giving to patients who are typically younger with an eligible vascular anomaly, I would say it's quite effective in those who fail other treatments. And this can be due to the anatomical location. It might not be amenable to surgical resection or sclerotherapy if it encroaches on vital organs or airways. And patients have had a great response on that. So I think looking at the anomaly itself and patient factors, we can say it's a good monotherapy, but it may need to, depending on, again, the anomaly and its consequences, we may need to supplement that with additional therapies.
Thank you. If there are no more questions, that concludes the session. Well done, all the speakers. Great job. Yeah. Okay, if you could vote for your people's choice. And again, there is more food outside. So don't go home without eating. Judges, can you go there?
Stop the recording.